So thank you for turning up on this Sunday morning, I see. So we'll be talking about human amniotic membrane preparation and applications. So as you all know, amniotic membrane is one of the most versatile tools for the ocular surface surgeon, not only for the ocular surface, now it is finding its use for the glaucoma surgeon, for the squint surgeon, oculoplasty, and even the retina people are dabbling with it. So for this talk, we'll limit ourselves to cornea and ocular surface primarily. And I'm Soham Basak. I'll be talking a little bit about the amniotic membrane preparation, how you can do it yourself if you have a very basic microbiology setup. I'll be joined by my co-instructors, Dr. Tuhin Chaudhary, Dr. Aditya Pradhan, and Dr. Nidhi Gatkar. So they'll be talking about how to go about using amniotic membrane in various surgical scenarios, from acute to surface reconstructions to adjuncts for different surgeries. So I've kept the topic as such, but mostly these are clinical scenarios with considerable overlap. So there is no way of sort of limiting yourself between these talks. But they'll be taking you over most of the surgical part. I'll be dealing mostly about the preparation part. So if you want to know a little bit history about it, so it goes back more than 100 years back when it was first used by Davis for dermatological purposes. And the first ophthalmic use is recorded for D. Roth in 1940. So that's also almost 80 years plus. And then this is Sorsby and Simmons. They have described it in how to use it in chemical injury. And this is Dr. Schaefer-Seng, who really popularized using amniotic membranes in the late 90s and then the noughties. So he has used it. He has multiple publications of how amniotic membrane can be used for pretty much every clinical scenario under the sun. And if you look at, this is just a timeline graph from the PubMed. So if you look at how the publications have increased, so again, it's like the late 90s when the amniotic membrane really became popular and people sort of started using it. So how does it all work? So without the labels, if you look at the basic histological diagram of amniotic membrane, it looks very similar like that of a corneal structure. So you have an epithelium, basement membrane, a stromal structure, then again a basement membrane internally. So this is the histology of it. So extremely similar to both cornea and conjunctival histology. So the other features would be that it is translucent. So even with an amniotic membrane on, you can sort of see what is going on underneath it. So it allows you to have some clinical evaluation. So it is avascular, and it is taken from the innermost layer of the placenta. The basement membrane again has structures similar to the corneal basement membrane. So collagen 4-7, fibronectin, laminin, and hyaluronate. Then stroma has again three parts: the compact layer, middle fibroblast, and the outermost acellular layer. Then that goes to the anatomy. Now the other advantages is there is no immunogenicity. So this is something which is connecting the mother and the child. So definitely this is something which has got no immunogenicity. And it has got extremely tough tissue. Although it's like so thin, it's very difficult if you want to try and stretch and tear an amniotic membrane, you will find it's very difficult. Because this is something which is bearing the weight of the fetus plus the fluid. And it has got good moisture retention capacity, also due to the presence of hyaluronate. And it has got this huge mix of all these chemokines and growth factors. Coming to this next. And another thing is this chemokines and growth factors, these are also preserved when stored at -80. So how does it all work? So one, it promotes epithelialization. So all aspects of it. It promotes cell growth, cell differentiation, and cell adhesions. It has got antifibrotic properties by suppressing the TGF-beta and myofibroblast differentiation. So as we all know, all these chemical injuries, Stevens-Johnson's, these are all basically induces a tremendous amount of fibrosis on the ocular surface. So acute stage amniotic membrane will help in arresting that fibrotic process. Anti-inflammatory properties, including IL-10, interferons, fibrin growth factor, TNF, and MMP9. So this is all prevented by it. It has got anti-angiogenic properties also. So it prevents corneal vascularization. Then there is antimicrobial properties with a little bit of mechanical barrier, and also this lysozyme and beta lysine in there. So types of surgeries, just briefly, my other speakers will be talking in detail. So we have an inlay technique. So you have a defect and you fill it up with amniotic membrane. That's the inlay technique. Then you have an onlay or an overlay technique. So you have the entire surface is unhealthy, you can cover it up. So whether it can be the cellular side down or cellular side up, this is a little bit of a debate, but each surgeon can have their own preferences. And there can be a mix of the two. So you have a lot of defect with an unhealthy surface, so you fill it up with a multi-layer amniotic membrane, and then finally cover it up with a larger sheet of amniotic membrane. Coming to the types, so what we are commonly used to using is a freshly harvested, which is then processed and then stored. Then what else we can have is the cryopreserved or the lyophilized. So the advantages, this can have a very long shelf life, you don't need to do the processing. Disadvantages, these are slightly less effective if you look at the literature, because since they undergo a lot of this processing, a lot of the chemical properties of amniotic membrane is lost. So it's more of like just a scaffold part which is the active. And then this is something which is known as a Oro Amsarta. This is developed by Dr. Bhaskar Rai Chaudhary. So this is basically a set of 2 silicone rings which can help as we can trap the amniotic membrane sheet in between those 2 silicone rings. So you have like a sort of a conformer. So you can make your own Procera basically. So the delivery system says freshly prepared. We are attaching it to nitrocellulose paper for ease of use. Amsarter, Procera, these are, we can just use it like a contact lens. So it helps in keeping it attached to the surface. Also, you can maintain the fondness along with it. And people have been experimenting with amniotic membrane extract drops, but there has been some regulatory warning from the FDA. So coming to preparation of amniotic membrane. So sourcing of the placenta. So you want an uncomplicated C-section for your placental source. Talk to your obstetrician friend who will be able to provide you with that. And all we need is basically a serological profiling. Usually all of these women undergo serology profile antenatally. In addition, you can always reconfirm it with the cord blood. Hep B, Hep C, HIV, syphilis. These are the commonly done tests. During the peak of COVID, we were doing the RT-PCR with the cord blood, but now slowly it is losing the relevance now. And always it is best to prepare it on the same day. So you should have your lab personnel ready and all the materials ready accordingly. So in terms of the equipment needed, you need to have a set of these graduated flasks, beaker and cylinder. This is the main investment that is required, a filter pump with a sterilized tubing which can be re-sterilized by autoclaving. Filter paper, pH meter, a digital weighing scale, sterile bottles and caps with heat sealing and labeling, and a laminar flow hood. So if you have a microbiology setup or an iBank setup, most of these are already available with you. So probably the filter pump and pH meter are the only things that you would have to invest in. And these are the chemical components which are required. So this is the main thing. So you can source from any of the standard chemical companies like Sigma Aldrich or High Media. So these are very standard chemical powder providers. So Dulbaka modified Eagles media, that's the main thing. Then sodium bicarb, antibiotics is streptomycin, penicillin, and amphotericin B. Reverse osmosis filtered water, glycerin, normal saline, nitrocellulose paper, and little quantities of sodium hydroxide and hydrochloric acid. This is for fine tuning of the pH adjustment. So if you look at it, this is very similar to composition to that of the MK media. So you have a nutrient part, then you have something which deterges us, and you have an antibiotic component. So this is the basically 3 things, and a buffer component basically, which is sodium bicarb here. So this is the thing, we bring it in an ice box. I'll just play the video and pause accordingly. So initially we start by extracting the cord blood. So just squeeze the umbilical cord, you will get some cord blood, which is then we do the rapid serological tests. Then this is the mixing of the Dulbaka media. So you mix it, and this is connected to the pH meter. So pH of about 7.2 to 7.4 is acceptable. So if not, then you accordingly, if you have a low pH, add sodium hydroxide. If you have a high pH, add some hydrochloric acid. That's how you adjust the pH. In small quantities, mix, and then take a reading again. So then this entire mixture is passed through the filter. This is the filter pump. So you pass it on top and put the filter papers in this component here, and then the pump system sort of drives it through it. So any impurities are taken care of. So this is your mixture of RO, glycerin, dalbacomedium, sodium bicarb, and the antibiotics. So this is your base fluid which is ready. So once this is going on, this filtration process takes a long time, about 30 to 40 minutes it takes. Once that is ready, you start preparing your amniotic membrane. So the entire placenta is thoroughly washed. So we wash it with normal saline, and in the normal saline we mix up some of the same antibiotics also. So it is basically we are washing it with a very dilute antibiotic solution. You wash it 3-4 times, take out all the blood, and this is how the amniotic membrane. So you just try to lift up the edges. At any one point you will have an anatomical plane from which you can directly take the amniotic membrane up, and the other person can just slowly remove the chorion part of it. And it comes off like this sheet, and it's very tough. So you should not be worried about tearing it, because it's very difficult to tear it also. And then this is the nitrocellulose paper. So once you have a considerable amount which is separated out, apply the nitrocellulose paper and then cut it in strips. So from one placenta, usually you can easily retrieve about 20 to 25 1 inch by 1 inch small squares of amniotic membrane. And the best part is if you're making it on your own, so you can have multiple sizes of it. So we usually cut it into 2.5 into 2.5 centimeters, but then some of them we keep it at a larger size also. So that is as per the surgeon's requirement. And then finally these are transferred to these small glass bottles. They are capped, and then a heat seal is applied on top. So you basically put a small plastic transparent sheet, and with a hair dryer you heat seal it, and then they are labeled for the date and lot number. And then this is stored at -80. So this entire process takes about 2 hours-ish to complete, 2 to 2.5 hours it will take to complete. So coming to the quality control and storage, so whenever you have made one amniotic membrane and the fluid is sent for culture in blood agar and SDA. So only after it has passed all the culture negative, then only we start the distribution process. Ideally to be stored at -80. Then you can store it for a period of 3 months very easily. -20 is also fine, but then the storage time becomes shorter. You should ideally maintain a distribution log, an adverse reaction log, and a freezer temperature log. So then you can have a good quality control. So to conclude, AMT is a very versatile surgical tool for the cornea and surface surgeons. And even comprehensive ophthalmologists should know how to use a very basic AMT for acute ocular emergencies. And novel applications, of course, are coming up. And if you have a very basic microbiological setup, with little more investment, you can learn how to make your own amniotic membrane. Thank you very much. And I'll be inviting my next speaker, Dr. Tuhin Chaudhary, for his part of the talk.
Back to Asmedike. Can you slide show? All right. Everyone, at the outset, my sincere thanks to Soham for the opportunity. So I'll be talking about these amniotic membrane transplantations in acute conditions like that chemical and thermal injuries and Stevens-Johnson syndrome and toxic epithelial necrolysis. So I have nothing to disclose about my financial interest. So whenever we are treating any patients with ocular burns, we have to promote this surgical therapy just to promote epithelialization of the cornea. So that can be achieved by either doing amniotic membrane transplantation that I will be discussing. So if you don't have amniotic membrane transplantations, then you can put large diameter bandage contact lens. Sometimes you can go for the stenoplasty, that is the stenos advancement flap. And even in some bad cases, we can go for limbal stem cell transplantation and conjunctival transplantation. So amniotic membrane can be used both as a graft, that is when this epithelial side is up, and it provides as a basement membrane for the epithelialization and or as a patch when this epithelial surface is down, and that way it acts as a biological bandage contact lens. It helps to in ocular surface reconstruction, promotes rapid epithelial healing, and restores limbal stem cell function to some extent. So this is the surgical video. This is a 8 years old child who had a tuna injury. So you can see this fornix is totally necrosed. This patient came 2 days after this injury. So in all these cases, we have to remove all those tuna particles along with necrosed scleral, this conjunctival tissues. So this is almost near about grade 6 chemical injuries, and in amniotic membrane transplantations in chemical injuries, it should be advised only in grade 3 to grade 6 as per those classifications. Grade 1 to grade 2, that means treated only by medical treatment. So first I have to go for this 360-degree congenital peritomy, and then putting this amniotic membrane. Here it will be as a graft, that epithelial side is up. So I am putting this fibrin glue. And then you have to just undermine inside this conjunctival peritomy. And in children, whenever you are putting this amniotic membrane, you should put that means suture. You can put either this tenonylon circumferential suture over at the limbus, or you can put you just suture it. These peritomy areas can be sutured by using Sevron Vicryl sutures. Because children will rub and sometimes it may dislodge. Now, these fornicial defects, we have to put another piece of amniotic membrane. Whenever we are putting 2 layers of amniotic membrane, at least the inferior layer should be sutured all the time. So here the superior layer, that I am just putting this fibrin glue, and then putting this conformer so that it will allow this adherence of this amniotic membrane over the fornix. And in children, all time you should put this suture tarsorrhaphy, and that should be removed after 2 to 3 weeks time. So this is the picture after 6 months. So this patient needs some sort of, there is no this symblepharon or anything like that. And there is no abduction or reduction defects, no ocular restrictions, anything like that. So if you don't have any sort of this fibrin glue, then you can use either Prolene suture or 40 silk sutures, which will be tied over the bolsters, and the suture should be passed from the fornix and tied over the bolsters here. And then you have to, so this is this, here I am putting this 40 silk suture. You can use this Prolene suture and put it over the bolsters. And in the lead margins, you can use this tenonylon suture. This is the schematic diagram. So here this is this. Here this is this 40 silk suture, and here this is this tenonylon suture. So, but always remember that in presence of scleral ischemia, that is this blanched out white appearing sclera, where only this amniotic membrane transplantation will not help. So in these patients, you have to go for tenonplasty. So this is the area where you can see that this is blanched out. This is scleral ischemia. So here only amniotic membrane transplantation will not help. So you have to go for tenonplasty. That is tenon enhancement flap. So what this in 1989, Tapping and Ream first reported tenonplasty, where it will act as a pedicle graft to halt the progressive scleral melt, and that way it facilitates conjunctival healing. So you can see that this is the patient who had this scleral ischemia. So you have to take this pedicle tendon graft from here and suture it in the limbus. Okay. So that way this scleral ischemic part will be, that ischemia part will be restored, that blood circulation will be restored. So sometimes what happens, if you want to go for this tenonplasty, this is the patient, he had this thermal injury. It came to us after near about 3 weeks. So this patient had this scleral ischemia and this sclerized bit char. So what to do? I have to put a layer of amniotic membrane over this charred tissue because I cannot suture it in the limbus here. So after just you have to separate the tenons tissue from the overlying conjunctiva and from the underlying that means sclera. Also you have to separate it from the this extraocular muscles. And whenever you are taking it, you should not pull it much because that will cause this fornicial shortening. So I am putting this over this necrosed area of sclera, putting a piece of amniotic membrane and then suturing this tenons and flap over the amniotic membrane. Then just putting suturing these tenons over that amniotic membrane. Then putting another piece of amniotic membrane here. And then conjunctival defect will be sutured. In all these cases, we have to put a bandage contact lenses. And now these patients came after 10 days. So this ischemic part is getting better. And after 3 weeks, you can see that ischemic part is getting, that means this vascularization has started now. So this is after 6 weeks, this patient developed this large epithelial defect. So at this visit, I started this patient on this autologous serum, 20%. And this is after 3 months, that ischemic part is getting better now. And now after 6 months, that there is no scleral ischemia. So there is vascularization, but this patient developed some sort of scarring. So at this visit, I asked the patient for penetrating keratoplasty, but patient just didn't want to go for that. But patient came after 2 years. You can see that the picture now, that there is remodeling of the cornea, and this patient has improved almost 636. Now another, this use of amniotic membrane is in acute condition is Stevens-Johnson syndrome. And aggressive control of ocular surface inflammation, especially with AMT during the first week of acute Stevens-Johnson syndrome, is most important. And amniotic membrane transplantation along with intensive corticosteroid therapy is the mainstay of treatment. And that way it significantly reduces the incidence of severe ocular surface scarring and longer term visual complications. And it is crucial that all ophthalmologists be actively involved early in the treatment process, as there is a limited window of opportunity for preventing ocular surface damage. This is a patient. This patient was, that means my friend, he's that is a doctor of medicine, and his teacher got affected and was admitted in Apollo in 2011. So all patients with acute SJs should be examined urgently by an ophthalmologist. So because that he knew about these complications, so he called me. And what I did this at bedside, I did this amniotic membrane transplantation. So at that time, I didn't put any sort of fibrin glue. I just put this amniotic membrane over the ocular surface and put a symblepharon ring. So all patients should be examined by ophthalmologists. So this is the pre-op picture, and AMT should be done as soon as possible in acute SJs or 10 within first week, preferably within 3 days. Before the onset of fibrinous inflammatory exudates, they will get collected in the fornicial area, and then that leads to cicatrix or symblepharon formation. So you can see that as because it was done very in urgent basis at bedside. So this is the patient. Even after 10 years, there is no lead margin keratinization or chronic SJS development. So this is the pre-op picture and this is the post-op picture. So any patients, as I mentioned, that with SJS or 10 who has eyelid margin involvement in the acute phase should have AMT, as I showed earlier. Also other signs like that, patients who have pseudomembranes and tarsal conjunctival or pharyngeal defects, because that defects will be fusing together, so you should go for AMT. So whenever you are putting this AMT, you should cover all the areas, starting from the lead, then tarsal conjunctiva, then pharyngeal conjunctiva, then bulbar conjunctiva, then this corneal surface. So this is the picture where it was just putting this AMT, and then they are putting this ocular surface with a simleferon ring in this case, and they have put another indigenous silver ring by IV tubing to keep the membrane deep in the furnaces. And then you can also suture it. If you don't have those things, then you can suture it and put this deep IV tubing also. The mechanism of AMT's beneficial effects is by minimizing the destructive effects of inflammation, by maintaining a healthier mucosa and eyelid structure. And while applying HAMs during the acute phase, it is important to cover as much as possible, as I mentioned it. And these techniques often necessitate the use of operating, that means room or microscope. So even you can, in these cases, if you don't have these facilities, then you can just put it like this way only. This is another technique. This was reported by Sonbag et al. So what they did that, they took this amniotic membrane and then put this cyanoacrylate glue over this area, and then they sutured, they put this amniotic membrane over this area, and then put this simleferon ring or this IV tubing, and then dip in the fornix, and then again put this glue here, and then put this amniotic membrane over that. And this glued AMT is quite good and offers an alternative to the traditional sutured AMT, and it is painless bedside technique that can eliminate the need of general anesthesia. And the long-term ocular outcome appears to be equivalent to published sutured AMT data. Sutureless AMT, that is this Procera. So what is Procera? This is basically a spread of amniotic membrane over a polycarbonate ring. And Procera, this polycarbonate ring may be, in infant it is 15 millimeter, and in adult it is 16 millimeter, this diameter, outer diameter. And Procera Plus is the cryopreserved amniotic membrane which is fastened up to an ophthalmic conformer. The inner diameter is 15.5, outer diameter is 21.6, and the height of the this conformer is 2.6. This is the sutureless AMT, this Dr. Bhaskar Chaudhary. This is this from the silicon tubing, silicon ring, and just it is snugly fitted. It's quite malleable and can be fitted in the deep fornix also. So this amniotic membrane is spread over the outer ring. And the inner ring is placed, and that way this is called M-setter, and it can be placed without any anesthesia at bedside. So it has been found that all the data showed that patients with, that means who didn't have AMT, they have poorer best corrected visual acuity, less than 20 by 200, even in 1 to 3 months post-operatively. And those who are having AMT, even long term also, the outcomes of visual acuity is quite better in comparison to no AMT. And on all the studies, they showed that there is minimal or no nil complications. And Procera may not prevent these cicatricial complications in fornix. So Procera just gives only superficial area, but it will not go to deep. Even Procera Plus also it won't go deep. So in these cases, the best is that you just use this M-setter or anything like that, it will go deep in the fornix. So to conclude, AMT has certainly an acceptable position in the surgical armamentarium of the ocular surface surgeon. Relative ease of the procedure, repeatability, and freedom from intraocular intervention makes it quite attractive surgical option. And it is crucial that all ophthalmologists be actively involved early in the treatment process as there is a limited window of opportunity for preventing ocular surface damage. In the meantime, if you have any questions, I can answer that also.
Yes, thank you so much, Dr. Chaudhary. So next we have Dr. Aditya Pradhan, who will be talking about use of AMT in surface reconstructions.
Good morning, everybody, and thank you, Soham and Scientific Committee, for this opportunity. So, I'll be just going through certain clinical scenarios in which the application of human amniotic membrane has saved the ocular surface and mostly the sight of the patient as well. So, I have no financial interest to disclose. So, the first case is basically a young male who had an injury to his right eye with an iron chain while working in a workshop, metal workshop. And there was a full thickness corneoscleral laceration and a corneal repair was done elsewhere. But then the wound was found to be leaking in the early post-operative period. So they applied a cyanoacrylate glue and a BCL over the sutured wound. And then since the situation was not improving, he was referred and he presented to the OPD of the clinic with complaints of redness and DOV. So this was the presentation in which you can see this vascularized scar and a huge chunk of cyanoacrylate tissue adhesive sitting over the suspected perforation and a BCL in place. So this was the AIOC2024. So you can see the outline of the BCL and the glue is causing some shadowing, so we can't really make out what is below that. So we took up the the wound to be explored in the OR. Just I have a short video of this. So the BCL is now being removed. So the plan was to remove the chunk of glue and then see what was below it. So the patient was adequately counseled that he may need a fresh surgery or something else. So we are not sure what to expect. So once the chunk of glue came off, another thing in these things is whenever you are applying any form of cyanoacrylate glue, the layer should be as thin as possible. There is no point in giving multiple drops of glue to make a thick plaque sit over the cornea that is more prone to dislodgement when the eyelid movements happen. So one thin layer of cyanoacrylate glue is more than enough to seal the perforation if it is within that acceptable range. So here, after removing the chunk of glue, we saw a huge crater sitting below it. So the plan is to cover the crater with a circular patch of AMT and then again cover the entire surface with a larger AMT. So now we are just focused on this. So this is the freshly prepared human amniotic membrane which Soham has shown. So then you just anchor it to the A by interrupted sutures. And then a larger, this is again fashioned from the previous membrane. You can refine it, you can cut it freehand, whatever way you feel comfortable. Glue is definitely an option. If glue is not available that day in the OR, you can always apply suture, that is the best. Sometimes the patient tend to rub their eyes, especially pediatric patients, so you may end up losing the amniotic membrane totally. You just that, then you just anchor this. The rest of the surface was, so that is why we have not extended the amniotic membrane beyond the corneal margins. This is an additional security measure. You could have managed with just one AMT, but then it's better that if you cover the earlier patch one as well. So this was on post-operative day 8. You can see the AMT has almost resolved, like sort of disintegrated because of the surface inflammation, but the ocular surface is stable, there is no active leak. This was about, you can see the evolution of the scar over time. This is after almost 200 days after the, now you can see more of the iris details. The pupil also can be seen in this photograph. So another lesson here, like Soham has, Dr. Tuhin has shown before, that don't be in a haste to do any keratoplasty after such surgeries, because you have to give time for the cornea stroma to remodel itself. So once the remodeling occurs, you would be surprised at how much the scar reduces on its own, or it becomes at least lighter to permit some form of less invasive modality like trial of a rigid contact lens or a scleral lens. So if the patient is not willing or not affording a keratoplasty, you can always counsel them that they can try, or we can try a trial of contact lens, maybe the rigid ones or the scleral ones. So this is another video of showing the excision of giant papillae. We see these cases now and then. So giant papillae cause two issues, that is the mechanical rubbing of the cornea causes a shield ulcer on the surface. So this was a boy who had this huge giant papillae in both the eyes, and he presented with shield ulcer in one eye. So the plan was to cover the shield ulcer with this amniotic membrane and then go and remove the giant papillae. He had a previous episode in which a supratarsal injection of triamcinolone was given, but this papillae kept on recurring. So, and the shield ulcer, because there was repeated breakdown of the epithelium, he was having shield ulcer. So that the one way to resolve it is to remove the offending structure, that is these giant papillae. So here you can just excise the ones, you need not go very deep into the tarsus, that will cause severe tarsal scarring. The ones just which are on the surface, which are offending, you can just hold them with the forceps and just shave them off or remove them off with a scissor. The surgery can be cleaner if you have access to a radiofrequency cautery, which many of the oculoplasty surgeons use it. So you can borrow that instrument from them and then use this to cause a much cleaner dissection and less bleeding on the ocular surface. So whichever way you choose or instrument you have access to, you can just use that method, knock off the offending papillae, and then the raw surface which is created after this, you just apply a amniotic membrane. In the end, you can place a symblepharon ring over the surface just to create more space and prevent the symblepharon formation. Since these patients are mostly in the pediatric age group, you can also do a tarsorrhaphy so that the child doesn't end up rubbing the eyes and removing the AMT somehow. And a sutured AMT is more preferable than glue, especially in the pediatric population. Just skip to that. So in this eye, already the AMT has been done for the shield ulcer. It is just the continuation of the same. I think the AMT part is not in this, but yeah. After you achieve such a surface, you just apply the AMT as been shown in the previous video. Yeah, this is I have put the absorbable sutures, Vicryl. This patient had undergone a pterygium surgery elsewhere, maybe a bare scleral technique, there were no records available, and then presented to the clinic with this. So there was a full thickness corneal abscess where the pterygium head was supposed to be there, and then this scleral melt which was infected. This later proved out to be fungus. So now the plan is to fashion a Tenon's patch graft to apply to the area of the scleral melt, and also do a large diameter eccentric therapeutic corneal graft to take care of this corneal abscess. So now we are anchoring you have to try and thin out the scleral patch graft as much as possible. The conjunctiva was badly necrosed in that, so the problem was to how to cover this patch graft, because conjunctival advancement was not possible. This was very close to the nasal side, and pulling of that would have incited more issues, maybe restriction of the ocular movements. So after anchoring the sclera over the scleral patch graft over the area of melt, now we are going ahead and doing a therapeutic penetrating keratoplasty. The graft will be eccentric. And then the plan is to cover this exposed sclera with human amniotic membrane, since access to conjunctival tissue was difficult in this case. Also at the end, it's a prudent idea to perform a tarsorrhaphy. Because these eyes are prone to melt, there is always some form of ischemia which won't let the wound healing, proper wound healing to occur. So tarsorrhaphy gives a lot of benefit in which the surface is at least stabilized and the wound healing occurs. So now we are using the freshly prepared human amniotic membrane, and then we are covering this area, and then a tarsorrhaphy would be performed over this area just to promote the wound healing. So I thank Dr. Nivedita Das, my colleague in the cornea department. So here there was a cyst in which she has done a scleral patch graft. He has used glue and interrupted sutures. And now she will be using a human amniotic membrane over the patch graft. And whatever, as she has mentioned, whatever you can approximate with the available conjunctiva, you can do that. But since you have amniotic membrane, so you are not that much afraid of a melt. Thank you so much.
Thank you for the wonderful videos, Dr. Aditya. And finally, we have our last speaker, Dr. Nidhi. We'll be talking about how AMT is used as an adjunct for various surface surgeries. And after that, we can have all the questions and doubts and discussions.
Good morning, everyone. Thank you, Dr. Soham, for making me a part of this IC. So I'll be covering how amniotic membrane can be used as an adjunct to ocular surface surgeries. And here we have multiple indications. Let's just see the most commonly scenarios that we face. Coming to persistent epithelial defects, now the cases which are intolerant or refractory to conventional treatment, like lubricants, punctal occlusion, a bandage contact lens, or tarsorrhaphy, we can use an amniotic membrane here. So this is a case of a post-infective keratitis with a PED. So it is important to first roughen up the edges, because a long-standing PED, the epithelium will not grow. Sometimes you also have to excise the redundant epithelium and put the amniotic membrane with a glue or maybe with sutures. So you can put individual sutures, or you can put a 360-degree purse string suture. This is another case who underwent ALK for dermoid, and it was a pediatric case having a PED. So here I did not use a suture, I just put it with glue, because then again the patient would have had to go under anesthesia, and the patient healed well. Another indication is using in ocular surface surgeries alternatively to conjunctival grafts, where there is a very large conjunctival defect in primary double-headed pterygioms, or it can be combined with the conjunctival autograft in recurrent pterygioms. So this is a case who had 3 surgeries for nasal and temporal pterygium, and this was the 4th recurrence. And this patient, I used CLAG for both the sides, only half of it, and the rest of it was covered with amniotic membrane, and the patient is doing good for 1 year now. Now this is a case just like Aditya sir showed, scleral melt post pterygium excision, but here the melt was quite large, and you could see the uvea as well. So here, even on giving the block, there was some bleeding in the anterior chamber. Conjunctiva was quite adherent, so first it was released, and I isolated the medial rectus to avoid any injury. Then a hand fashion graft was placed. Again, there was not much conjunctiva here or tenons, so I put an amniotic layer first, and then I took a CLEG from the other eye. Unfortunately, this patient was lost to follow-up, so I really don't know how he's doing, but from my side, this is the best that I could do in this case. This is another case of a scleral graft melt in rheumatoid arthritis. Already one sitting of amniotic membrane and scleral grafting was done, and then the patient presented with this like a stuck-on appearance of the graft. There was an impending choroidal detachment, vitritis was present. Doing any kind of grafting in such autoimmune cases is very risky because that can also melt. So first the patient was sent to a rheumatologist where she was given pulse dose steroids intravenously, and then intravenous methotrexate was given. That was the choice from the rheumatologist. And once the patient stabilized a little bit, the vitritis reduced, I did try to do a regraft here. So the previous graft was actually stuck on, so that had to be removed, and then this graft was placed. There was quite a large defect, and the surrounding sclera was also quite thin, so I could not really rotate the sutures, and I thought that a single layer amniotic membrane would not be enough. So a second layer was put, and a tarsography was done after that. All the systemic treatment was continued, and this is how it looked at 2 weeks, 2 months, and we are waiting for the vascularization to happen, but no melt. 4 months, and this is at 6 months, and planning to do the suture removal now. Another indication that sir has covered is using amniotic membrane in VKC for ulcers or giant papillae. Coming to perforations, that is most commonly seen by all of us. Here a multi-layered amniotic membrane can be used, or it can be used along with tissue or Tenon's graft. So this is a case of patient having a very long-standing foreign body which induced stromal necrosis. So what we need to remember is whenever we are removing the foreign body, all of it should be removed, else the residual iron foreign body or any other foreign body will either cause an infective keratitis or will cause stromal necrosis. So on removing, I saw residual foreign body still there, and there was a perforation which could not be handled with cyanoacrylate glue. So a lamellar pocket was made here so that I could do a multi-layered amniotic membrane. So first layer was inserted into the pocket with glue, and then covered with a second layer with glue and sutures. However, on forming the AC, I was not sure that it would sustain or not on follow-up. So just a thin layer of cyanoacrylate glue was put, which I thought I'll remove very early. And this is how the patient looked at 1 week. And this is after the glue and suture removal of the patient. This is another case who was a case of failed glue BCL done by me only. And the patient came with a flat AC after 3 weeks. And earlier there was a central thinning and perforation, but now the adjacent tissue also had thinned out quite a bit. Now this patient was on warfarin, and we could not plan a keratoplasty for her. She was not given clearance for a surgery. So on that day, whatever was available, my plan was to put it there, either Tenon's or multi-layer amniotic. But I had a very small cap of desect tissue, which was fresh, and that is what I planned to put here. So first layer was inserted into the lamella, and the second layer of desect cap was sutured. This is how the patient looked at 3 weeks. We had a good thickness achieved in the center, and this is at 12 weeks. Now the patient is awaiting clearance for a keratoplasty. Now, this is a case of stromal melt. There is not a frank perforation. This patient had B-cell lymphoma and had undergone radiotherapy and then developed a seventh nerve palsy and lag of thalamus, and that's how he had exposure keratitis and a stromal melt. And here again, an amniotic membrane with a residual DSEC cap was used. Sometimes if we do not have any tissue, obviously tenons comes to the rescue. Tenons is quite elastic, so even a small graft would suffice. So here sutures have to be given because it swells up later on and then it can get dislocated. Another case, this is a one-eyed case, post-traumatic, previously recorded 0.9 CDR. There was a bleb leak, and for that, I put a large size BCL first, but on follow-up, there still was a leak. So then here I plan to form the AC and do a graft. So amniotic membrane can be used to repair blebs. Due to long-standing flat AC, a lot of anterior synechiae had formed. Normally, if we have a leaking bleb, we might just remove the conjunctiva and put an amniotic graft as an inlay. But here, the rest of the tissue was quite tough, so I just thought of lifting it up and placing amniotic membrane as an inlay inside. This patient did quite well. His IOP was very well maintained, bleb was formed, and later on a cataract surgery was done, and he has ambulatory vision in one eye. This is a case post-SICS who had a tunnel deroofing, and it was just impending perforation. You could see the anterior chamber from the superior aspect. And so here, as I started the surgery, there was a perforation. There's no history of trauma. His IOL has been placed like that only since the beginning. And here, again, a hand-cut graft was used, covered by amniotic membrane. However, the rest of the conjunctiva I felt inadequate to cover the graft, so I just took a small inferior autograft. And the patient is maintaining 6/9 vision since then, awaiting suture removal. Another indication is to remove OSSN or any suspected mass. Here, what you need to take care is you need to have an adequate free margin on all the sides, including the epithelial site, which needs to be sent for histopathology. And the tumor is removed with a no-touch technique. A double cryo-thaw is done, and then you put glue and the amniotic membrane and cover it with BCL. This was the post-op of the patient. So thus, there are various presentations of OSSN for which amniotic membrane can be used. This was a very challenging case which had 8 clock hours of OSSN. And removing this and putting an amniotic membrane, there is a very high risk of causing a LSCD, but this patient did well. Another indication is to remove symblepharon. Now this patient presented 6 months after chemical injury with a symblepharon, and what I did was I used a conjunctival autograft near the limbus And for the rest of the symblepharon excision and covering up, I use the amniotic membrane. And this is a case which actually had undergone amniotic membrane transplantation after a chemical injury and then 6 months later had a symblepharon. So it is not that patients who have not got treatment will have a symblepharon and who have got would not. This can happen to patients who are doing well also if they are lost to follow-up many times, or if you stop using the steroids, then chronically they might develop a symblepharon and pannus. So this is how the post-op looks for this patient. This is another indication, patients having very long-standing status post-chemical injury will require a combined procedure of symblepharon excision as well as doing a slit. And amniotic membrane is very important here. First, you need to find a plane and excise all the pannus. And then you take the limbal cells from the other eye, cover the bed with amniotic membrane with glue, and then place the small lenticules over the cornea and then attach them with the fibrin glue. And then cover up with the bandage contact lens. So this is how this patient looks at 3 weeks, but still awaiting follow-up of this patient. So to summarize, amniotic membrane is a very good adjunct for ocular surface surgeries, and anything that you need to plug, prevent or protect, amniotic membrane can be used. Thank you so much for your patient hearing.
It was a wonderful collection of surgeries, Nidhi. Thank you so much. So we are now open for any questions and any comments you are free to ask. We still have about 15 minutes to go. Post-surgery medical management. Would you like to answer, sir?
So, for chemical injuries, what I feel that you should give these steroids, topical steroids. In cases, if there is grade 6 injury, there is scleral ischemia where you did this tenonplasty, then you have to go for oral steroids also. So topical steroids initially for 10 days you have to give the strong like dexamethasone or prednisolone acetate 2 hourly, along with this antibiotic coverage and Midriatics. Then this collagenase inhibitors like doxycycline, and then these patients have usually some sort of glaucoma, so you have to give this oral acetazolamide, and then lubricating eye drops. And if the patient still now is not getting better, or after sometimes you feel that this ocular defect is persisting, then we can go for this umbilical cord serum, or even this topical amniotic membrane extract also nowadays, but we have not used so far like that. ভাই এটা একটু বন্ধ করে দাও না, দেখো কি হচ্ছে এখানে। Immunomodulators at this stage won't help because it is acute conditions. So in this case, only oral steroids may help. But thing is that the mainstay of treatment is tenonplasty or scleral patch graft.
It induces more inflammation and fibrosis. So the better option is to just shave it off and then put a AMT. There have been published reports in the literature that there is recurrence in spite of applying AMT. So MMG has also been advocated by one group that instead of putting a amniotic membrane, just put a buccal mucous membrane graft.
cryotherapy will definitely cause that means this fibrosis, and sometimes this they can develop the cicatricial entropion also. Okay, so if you just cut it, and sometimes if you have diamonger polisher, you can just polish it. And I have found that if you put this topical bromonidine or anything like that, this the bleeding will stop. And then if there is some oozing of blood, if you put this amniotic membrane, that oozed blood will act as a fibrin glue.
Thank you so much. If there are no questions, I think we can conclude the session. Thank you for being with us till the end.
দুটো মেমোরিয়াল PGT ছিল। প্রগতি প্রগতি নামবে। এক ছবি তুলে দাও যেটা আমাদের চারজনের। হ্যাঁ হ্যাঁ দিয়ে দিচ্ছি। একটা ফটো তুলে নাও। हाँ अरे तो आ गया। एक बैठ के एक खड़ा होके, ठीक है। কাট গিয়া নেই তো, কেটে দেয়নি তো? দাঁড়িয়ে দাঁড়িয়ে ছিল না, দাঁড়িয়ে ছিল একটা ভাই, চেয়ারগুলো যা করেছে না। তুমি বুঝবে।